Hi, everyone. As we start our course, I wanted to begin by thinking about the PT's role in health promotion, fitness, and wellness. Before we get started, just a devotional thought. A lot of what we'll be talking about during the course is related to the whole Creation Health initiative. And when we think about the basis for Creation Health, it really has to do with whole person care. And that's consistent with God's plan that we be happy and we live well. And so that called to mind this verse from Thessalonians where we're told that we should encourage one another and build each other up. And so to me, this class has to do a lot with using our gifts for the benefit of others. Our objectives in terms of our first lesson would be to construct a holistic, multidimensional view of health and wellness. Also to be able to utilize epidemiological data and thinking about the most prevalent types of chronic disease and disability to help us anticipate public health needs and also to consider the impact of these health needs in our current and future practice as physical therapists. We will be looking at the role of personal behaviors and also contextual factors, so things like environment and resources in shaping personal health and wellness. As we think about health promotion, we should really think about what it means to be healthy. And so if you look at this World Health Organization definition, you'll see that they say that health is not only the absence of disease or infirmity, but also a state of complete physical, mental, and social well-being. And so that's a little bit of a shift from the traditional medical model where we only consider someone's health after they've already had an illness or an injury. As you can see from the World Health Organization, when we say that someone's healthy, it's not only their physical being. And so we need to consider these other dimensions. These come from the first chapter in your textbook. And according to the National Wellness Institute, the priorities of wellness would include things like physical wellness, of course, but also spiritual well-being, social wellness. So what type of relationships do we enjoy? Psychological wellness, and we'll talk a little bit about mental health issues and how that affects overall wellness, emotional wellness, and intellectual wellness. The other thing that we want to think about is population health. What are the national health priorities? And so on Canvas, I posted a link for you to Healthy People 2020, and that's an initiative that comes out of the U.S. Department of Health and Human Services, the Office of Disease Prevention and Health Promotion. And as you read through the Healthy People 2020 topics and objectives, you'll see that there's a ton of areas where physical therapists can potentially have a huge impact. Things like musculoskeletal issues, arthritis, osteoporosis, chronic back pain, which happens to be very prevalent among the American population. Cancer, diabetes, and so as we start to think about these things, think about the role of physical activity and exercise in preventing both cancer and diabetes. I've highlighted in red disability and health and physical activity, which are two huge areas that should obviously involve physical therapists. Cardiovascular health, heart disease, and stroke. Also, overweight and obesity, which has a lot to do with nutrition, but also, again, physical activity. There has been a shift in focus now towards older adults, and we're talking a little bit about the graying of America and what that means, the shift in population proportions towards older adults, and what that means in terms of resource allocation. And then also respiratory diseases, things like COPD, and the role that physical therapists play in preventing and managing those conditions. Looking at the epidemiological data, one of the things that we should pay close attention to are the 5 leading causes of mortality. And so if we look back in American history, what we'll see is that in the past, most of the major causes of premature mortality were infectious diseases, things like tuberculosis, diphtheria, for instance. And what we currently see after the advent of antibiotics is that we've shifted away from those infectious conditions and towards other types of chronic disease like heart disease, cancer, CVA, diabetes. And so this is kind of a good news, bad news situation. The good news is if you look at these 5 major causes of mortality, you'll see that our individual behavioral choices are a primary risk factor. So things like lack of physical activity can be tied to each of these conditions. And so it's kind of good news in a way, because if it's tied to your personal behaviors, it means that you have the power to change those things. Unfortunately, the motivation or ability to change those things is obviously somewhat limited. Otherwise, we wouldn't be seeing such an increase in prevalence. The other thing that we should think about is that not only do these conditions constitute a major cause of mortality, but they are also the leading causes of physical disability as well. And so as we start to think about these behavioral risk factors in terms of chronic disease, this chart might help us a little bit. The thing that we want to really keep in mind is that there are certain commonalities here. And so you can obviously see my bias as a physical therapist. As we look across the board, the role that lack of physical activity and exercise plays in terms of increasing risk for cerebrovascular disease, coronary vascular disease, cancer, COPD, type 2 diabetes, and even osteoporosis. Also, a lot of these are tied closely together. We know that sedentary lifestyle is closely linked to being overweight or obese, and so is improper diet. We'll talk about the role that stress or inadequate rest has in increasing our risk of chronic disease, and then, of course, tobacco use. As we consider the role that obesity and overweight plays in terms of chronic disease, we want to think about the escalating prevalence. And this is particularly true in children and adolescents. So as you look at this graph, what you'll see is that adolescents, people that are aged 12 to 19, have an increasing prevalence of being overweight or obese. And this chart compares not only males and females, but also certain racial and ethnic groups. And so as you look across the bar charts, you'll see that certain racial ethnic minorities are more at risk for overweight and obesity. African Americans, for instance, and Hispanics, in comparison to whites or Caucasians. But it's problematic across the board, so no one's really safe from this. In adults, the prevalence of obesity is also increasing. And so there's 2 things here that should really concern us. First of all, it's projected that by 2030, 50% of the American population will be obese. And so that's concerning from a healthcare perspective because it's closely linked with the prevalence of these chronic conditions, but also because as physical therapists, how difficult is it for us to assist someone in rehab when they're overweight or obese? It places a big strain on the healthcare provider's body as well. So I suspect with the growing prevalence of obesity in overweight adults, we're also going to see an increase in prevalence in occupational injuries to people like physical therapists and nurses who are working harder to have to help these patients to move around. Think about what it's like to try to get someone out of bed if they're overweight or obese. And so if half of your patient population consists of people that require that extra effort from you, what's the wear and tear like on people's necks, backs, our other joints as well? It's likely that we will see an increase in occupational injuries, back pain, neck pain, etc., in physical therapists as the composition of overweight and obese adults continues to change, or if it continues to change. Let's be optimistic, right? Additional risk factors, we're all aware of the APTA's new Move Forward campaign. And so a lot of that comes from the epidemiological data that shows that 60% of opioid overdoses occur in people with chronic pain. One of the advantages in terms of being a physical therapist is that we take a very active approach towards controlling chronic pain. What that means is that we are targeting not only the symptoms of pain, but the cause of the pain as well, and teaching the person with the pain effective self-management. So we're putting them in control so that they're not relying on a medication. As we think about addiction and some of the other chronic health conditions that we've just mentioned, there's a large prevalence of mental health issues. And so there's a close tie between physical disability and mental health issues, as well as an increase in prevalence of mental health issues within the population as a whole. And so right now, in terms of prevalence, they say that nearly 1 in 25 American adults live with a serious mental illness. And then in terms of lifetime incidence, 1 in 5 adults will experience mental illness at one point in their lives. So let's think about the most common types of mental health issues. And as you look towards the right side of this graphic, you'll see that some of the most prevalent types of mental health issues have to do with depression and anxiety. And the reason why I'm calling your attention to that is that one of the most effective non-invasive interventions, meaning not associated with the use of medication, would be exercise. Exercise has been shown to be highly effective in reducing the severity of anxiety and the severity of depression, but also the likelihood of these two conditions. So both as a treatment intervention and as a preventative measure. And so typically speaking, traditionally, PTs haven't seen individuals who are referred specifically for mental health issues, but that could change. If you have a practice that caters to fitness and wellness, one of the potential areas that you might market to would be psychologists and psychiatrists using evidence that shows that exercise is effective. The other reason that we really want to be aware of this is that patients with disability, with injuries and illness, chronic illnesses that are being seen as a primary diagnosis by the physical therapist also have a high likelihood of having depression or anxiety. And so we want to be able to recognize the signs of these conditions and refer as appropriate to a psychologist or a psychiatrist. Unfortunately, mental health issues in this country don't get a lot of time or attention, and they also don't have enough, there are inadequate resources that are being devoted towards this issue. And really, if you look at the epidemiological data, because it is so prevalent, you would hope that our priorities would shift towards addressing this. Sexual health, like mental illness, is one of those areas where it's unlikely that the physical therapist would be the first provider to see the patient. But because of the prevalence of HIV and AIDS, this is something that it is likely that we will see during the course of our practice. And so when we think about the prevalence of things like HIV and AIDS, we want to consider the impact that has on physical functioning. There is a high likelihood of chronic pain in patients with HIV and AIDS, and also there are other health promotion issues, physical fitness, aerobic conditioning, just in terms of exercise and the health of the immune system. It really can be a preventative intervention as well. Getting somebody with HIV or AIDS on a comprehensive physical fitness program, for instance, can boost the health of their immune system and prevent some of those secondary conditions. This just gives you a breakdown to kind of address some of the biases that people may have in terms of what causes or what contributes to HIV infection. And really, all segments of the population can be affected, including heterosexual males and heterosexual females. Access to care is something that we spoke about in our Integrated Cases course, and I'm sure that you've encountered this as an issue in your clinical experiences as well. And so when we talk about limited access to care, we want to consider things like insurance coverage and health-related costs and the lack of appropriate financial resources. But we also want to think about social and cultural barriers to access. Things like the individual's willingness to seek healthcare in the first place. And so, what can contribute to someone's lack of willingness to seek appropriate attention from a healthcare provider? And if you think about that, what should come to mind is things like potential bias that the patient may face. So racism is obviously a bias that occurs throughout our population or throughout our society, unfortunately, including healthcare. And also not only biases in terms of race, but gender identity. We know that homosexuals and transsexuals, for instance, have a higher prevalence of certain preventable health conditions. They also have a higher prevalence of certain health risk behaviors like tobacco use, but very often they're discouraged from seeking health care because they're afraid that they'll be judged. One of the things that we can do to help reduce these barriers is to create diversity within the health professions. So as physical therapists, we want to seek to increase our diversity as a profession, including more ethnic minorities, racial and ethnic minorities, but also making sure that patients can identify with us, breaking down those psychosocial barriers. Some of it has to do with language sometimes. Patients tend to appreciate when the healthcare provider can communicate directly with them without the use of a translator. So people that speak a second language are often a very important asset within health promotion and wellness. But also our attitudes, making sure that we're culturally aware. And I think here at ADU, you guys have a little bit of an advantage with this because of your international service learning experience, and also because we tend to be a diverse group. Other things are quality of care, right? Very often people have stress or frustration in dealing with healthcare providers. So if you've had a negative experience in the past, you're less likely to seek help in the future. Let's look at our professional mission and vision. We don't think too big, right? What's our thought as physical therapists? We're moving beyond the thought of what we can do for the individual. And I don't want to say we're moving beyond. We're really just expanding from individual health to community level health. And the reason I say that is if look at the mission and vision statement, transforming society. So not only are we helping individual patients, but we're thinking about the community or the population as a whole. And how are we going to transform society? We're doing it by optimizing movement to improve the human experience. So let's think a little bit more about what this means. First of all, our role identity as physical therapists is beginning to shift. We recognize that we are an evolving profession. And so when you look at that mission statement, one of the biggest things that it does is it focuses our attention on movement as a key determinant of health and health-related quality of life. So when we say we're going to transform society, we do that through movement. And so think about what that means now in terms of the national health priorities that we just looked at in terms of Healthy People 2020 and the epidemiological data and the role that physical activity plays in terms of preventing chronic disease and disability. So movement really is a key determinant, isn't it? And then the shift in healthcare in general from that traditional paternalistic medical model where the physical therapist or the physician or the nurse, etc., is seen as the expert. And then from our expertise, we dictate to the patient what they need to do in order to be healthy. So we're getting away from that, which is a good thing, right? And hopefully we're moving closer to this biopsychosocial model where we look not only at the individual, but contextual factors that could affect their health and wellness. Things like access to care, like we just mentioned, but any other potential barriers to a healthy lifestyle, such as the types of food that the person sees on a day-to-day basis. So if you're talking about a child, what types of food do people eat culturally? Do they live in a neighborhood where the most prevalent type of food comes from things like McDonald's, Burger King, etc.? Do they live in what's called a food desert, meaning that are there grocery stores that the person can get to very easily where they can buy healthy foods like fresh produce, etc.? And also, what are attitudes like around them? Do they live in a community where physical activity is really fostered and encouraged? Or do they live someplace where physical activity maybe isn't seen as being that important? So those contextual factors and the shifting or expanding focus from the individual to the community as a whole, knowing that we each can support each other and encourage those healthy behaviors when we work well as a group. A lot of your own role identity now as a physical therapist is hopefully shaped by where you received your training. So we want to look not only at our professional identity in terms of the APTA vision statement, but let's look at our professional identity as alumni or almost alumni of ADU. So the mission and vision of our university has that focus on whole person care, which is really an asset in the changing healthcare environment as we continue to live those healing values of Christ. And I mentioned before the creation health priorities and how those really closely align with the national health priorities and the behavioral risk factors for chronic disease and disability that we'll be talking about throughout the course. If you read the article on Canvas by Janet Besner, you see that she outlines our role in terms of health promotion according to whether or not we're playing a role in primary prevention, secondary prevention, or tertiary prevention. And so very typically, physical therapists have in the past focused primarily on tertiary prevention. And what that means is that we see patients after they have an illness or an injury. So, for instance, if you have an individual who's experienced a CVA, after they experience the CVA, they come to physical therapy and we work with them to help regain their strength, their flexibility, and teach them how to transfer, ambulate, etc. And so even if they do have some residual impairments, hopefully they're able to perform their ADLs and maybe go back to work and accomplish some of the other goals that they might have for themselves. That would be tertiary prevention. We're preventing functional impairments and we're preventing the person from having participation restrictions. So now we're expanding that, right? Not only are we seeing patients after they've had an illness or injury, but hopefully we're working with individuals before the illness or injury even develops. And so what it means for us in terms of primary prevention is doing things like community education for people that haven't experienced a health problem yet and really want that to stop that from even happening in the first place. An example of this would be a physical therapist that goes into a grammar school, for instance. So goes and speaks to children between the ages of 5 and 7, maybe, about eating healthy and exercising. So we're not really worried about a 5 to 7-year-old having an MI or having atherosclerosis because that's unlikely to develop at such an early age. But we know that the habits that we establish in childhood very often follow us through our lives. And so establishing those healthy habits early on is a form of primary prevention. Secondary prevention, an example of this would be a physical therapist who goes to a community health fair and does blood pressure screening. And so that person already has the condition, right? Because if we take your blood pressure and it's elevated, you already have hypertension. But we know that hypertension is a risk factor for CVA. So hopefully by telling you that you have hypertension and referring you to an appropriate healthcare provider who can prescribe medication and hopefully having the person begin an exercise program so that they are also actively participating in their risk reduction is a form of secondary prevention. So PTs need to continue to expand our role in primary and secondary prevention, as well as continue to perfect evidence-based practice for tertiary prevention. The other thing that we want to acknowledge in terms of our assets in responding to public health needs would be that physical therapists are well recognized as being experts in patient education. If you look at the guide to physical therapy practice across the board, you will see patient education mentioned as an intervention. And that's because we fully recognize that that's one of the most important things that we can do. We teach someone about their injury or illness, and then we teach them things that they can do on their own to actively promote their own health and wellness. We want to acknowledge that very often having an illness or an injury works as a teachable moment. So what that means is that, say we're working with someone who has back pain. So it's their first time having back pain. They're really eager to get rid of it, obviously, and get back to the things that they normally do and enjoy. And so we start them on an exercise program. And maybe this is someone who has never exercised on a regular basis before. And so as their back pain gets better, they're becoming more and more physically active, and they're beginning to enjoy it, or at least increase their confidence level in exercising independently. And they may be more motivated to carry through with that in the future, number one, because they're already doing it successfully, and number two, they've experienced negative consequences of a sedentary lifestyle, and they don't want to go back to that. So that teachable moment then becomes an opportunity for us to do health promotion while we're addressing the primary condition. PTs are also recognized as being essential members of the interprofessional care team. So that's very important when we look at some of these leading causes of chronic disease and premature mortality. Because obviously, as physical therapists, we want to play a role in things like diabetes, but it is likely that that patient will also need the attention of a physician, perhaps a physician assistant, a nurse practitioner. They may see a nutritionist or a dietitian. The thought is that we are not practicing in isolation, and we choose, or the patient should be choosing, members of an interprofessional care team based on his or her individual needs. So it changes on a case-by-case basis. And with direct access, if you are the primary entry portal for that patient, if you're the first healthcare provider that that patient sees, then it's up to you to suggest other specialties that may be of benefit to them. If you look at the epidemiological data in terms of healthcare expenditures, you'd be surprised because we can see that the U.S. really leads globally in terms of the amount of money that we spend on healthcare, but unfortunately we lag far behind in terms of our outcomes. So while we spend the most money across the board in terms of healthcare costs, we have the least successful, I don't want to say the least successful, but there certainly are things that we could be doing better in terms of our mortality rate, our disability rate, and the overall population's level of function. So we want to start thinking about how cost effective our interventions actually are. Where are we spending the most amount of money? And so if we're spending a large amount of money in taking care of people with chronic disease, excuse me, number one, how effective are the interventions? And number two, what can we do to effectively prevent these conditions from even happening in the first place? And so PTs are very cost effective in general, but especially cost effective in terms of prevention. Think about the graph that we looked at earlier and the role that physical activity and exercise plays. How cost effective is it to have someone begin an exercise program with a physical therapist versus taking care of that person with hypertension who then goes on to have an MI and maybe needs a coronary artery bypass graft and cardiac rehab, etc. Some of the other things that we want to think about in terms of changing healthcare needs are the shift in demographics towards the older adult. So you'll hear the term the graying of America, and really what that means is that the segment of the population that now has the largest number of people is shifting towards adults who are over the age of 65. And so how does that shape our future practice as physical therapists? And also, what can we do to be promoting healthy aging? The other area that we'll think about closely are the healthcare needs of people with disabilities. There are currently approximately 54 million Americans currently living with physical disability and mobility impairments. And those mobility impairments place those individuals at risk for secondary conditions. So what that means is that people with things like multiple sclerosis or spinal cord injury as a condition that causes reduced mobility are also at higher risk for some types of secondary conditions like diabetes, like hypertension. So what can we do to reduce the likelihood of those secondary conditions in people that already have an existing disability? This graphic just kind of gives you more of an overview of what I was talking about with the graying of America. It compares the largest segment of the population in 1970 to the largest segment of the population in 2012. And what you see is that in 1970, the largest segment of the population were people that were aged 6 to 24. And as those so-called baby boomers continue to age, we see that that segment of the population has now shifted, and the largest amount of people now exists between the ages of 48 to 66. I mentioned before how people with disabilities are at higher risk for secondary health conditions. Unfortunately, they're also one of the largest underserved groups with regards to health promotion. And some of that might be because when you think about these people seeking healthcare attention, very often the entire appointment is devoted towards managing the disability, with very little time devoted to things like counseling the patient for exercise or proper nutrition or weight management or tobacco cessation, etc. If you look at the epidemiological data, if you have an existing mobility impairment, you are also more likely to have certain chronic conditions like diabetes. You are more likely to be overweight or obese, and you are less likely to pursue proper nutrition. People with physical disabilities have lower rates of physical activity, so PTs would be a great asset in this regard too because of adapted exercise strategies. There's difficulties in accessing screening, so for primary prevention and health behavior counseling, as I just mentioned. And also we need to think about socioeconomic status, the fact that people with disabilities have barriers to education, employment, and community participation, which we know are also risk factors for chronic disease. So here we see the importance of the ICF model, because you can really have two people with an identical pathology or identical physical impairment, and their level of disability will vary based on those contextual factors. For instance, if you're someone who has a spinal cord injury and your primary means of mobility is a wheelchair, but you live in a town or community that doesn't have ramps or curb cuts, then it could be really hard for you to get around versus someone who lives in a very accessible community where the wheelchair really does provide for a lot of mobility for them. So here's a quote that tells us is that we shouldn't confuse physical impairments with disability, because a disability is really an interaction between the person with the health condition and aspects of his or her environment. That also tells us as PTs that we have to look beyond the individual to aspects of that environment that can either promote or inhibit their ability to engage in things like physical activity, recreation, employment, etc. So here's just an overview of why the ICF model is so important, not only in rehab but in health promotion, because of the interplay between the health condition and activity levels, participation, but also how personal factors and environmental factors affect activity levels as well. We also want to make sure that we know the difference between impairments and disabilities. An impairment itself is the functional limitation caused by the physical deficit, such as being reliant on a wheelchair as a primary means of mobility, versus the disability, which is the loss or limitation in opportunities to engage in community life. When we think about those limitations, we do it by comparing the person with the mobility impairment to the population as a whole. So are people with the impairment able to participate at an equivalent level with their non impaired peers. And so this not only has to do with the physical issue, but also because of mental health issues or social barriers, attitudes, stigmas that people with disabilities might encounter out in the community. Secondary conditions associated with disability can also further impair function. So people with pain, we know that pain can stop people from moving around, and so that really can set itself up into a self-perpetuating cycle. Very often there are certain conditions that are tied to fatigue, things like ALS, Guillain-Barré syndrome, multiple sclerosis. Really, as a function of the pathology, patients have limited energy levels. That can be self-perpetuating as well, because as weird as it sounds, the less you move, the less likely you are to move in the future. So exercise can really help to reduce fatigue in the long run. Sleep disturbances are very common in people with disabilities, either because of pain level or maybe just as a function of some of the medications or the disease itself. And dealing with a disability can be very stressful, so we know that there is a large likelihood of anxiety disorders and depression in people with physical disabilities. Again, looking beyond the personal factors to the larger environment as a whole, we recognize that most of the factors that are associated with health disparities are beyond the control of any single individual. So very often we can choose our own health behaviors, but we're either inhibited or maybe encouraged by the things that are happening around us. So we think about personal factors like genetic risk factors or even behavioral risk factors, the presence of disease or disability in and of itself. And we also acknowledge the role of your family, your friends, your social networks, relationships within the community, and public policy, right? If we think about wheelchair mobility, for instance, and the impact of the American with Disabilities Act, which then compelled many community-level organizations to make accessible buildings or make sure that there are policies in place within the workplace that protect people with disabilities from discrimination. As we talk about the larger aspect of social determinants of health, you'll see this diagram helps us out a little bit. So when we talk about risk factors for chronic disease, for instance, we can look at the individual. What's the person's age, their gender, and those factors that might be related to genetics or being overweight, obese, etc. We think about lifestyle factors, again, of the individual. Does this person smoke? Do they use any types of illicit drugs? What type of diet do they follow? And then we think about their social and community networks. Are these an asset or a drawback? You, for instance, are more likely to use tobacco if you live in a house with other people that use tobacco, or you're in a workplace where other people use tobacco. And then we think about other types of living and working conditions. Is this person affected by unemployment, which obviously can affect your access to health care because of insurance coverage and financial resources? What's their water and sanitation like? Do they need to worry about diseases that are transmitted by say, bacteria in the water? Things like hepatitis, for instance, because of poor sanitation. Access to healthcare was something that we talked about. Do they have safe housing? Do they have access to education? And then the general socioeconomic, cultural, and environmental conditions, some of what we talked about in terms of cultural biases, etc. Even governmental policies like the Americans with Disabilities Act. I mentioned before that people with mobility impairments are more likely to have anxiety and depression. People with chronic disabilities are also more likely to report poor life satisfaction. And this is problematic for a number of reasons. Obviously, we're concerned with our patients' health-related quality of life, but also life satisfaction is a predictor of longevity. So you are more likely to experience premature mortality if you're not satisfied with your current life. And also, you're more likely to have a shorter lifespan if you do have some of these psychiatric comorbidities like anxiety and depression. There's also a direct correlation between life satisfaction and positive health behaviors. So, as we talk about health promotion strategies, patients that are depressed and anxious may have less motivation to engage in self-care. And so, really, it's important that we are addressing those other issues as well when we're trying to promote exercise, physical activity, and some of those other positive health behaviors. Other factors that affect quality of life, some of the secondary conditions that we talked about: energy level, pain, proper sleep and rest, but also psychological outlook. Body image can sometimes be a problem with people that have physical disabilities. For instance, a patient who's experienced an amputation, their body image might change. Their role perception and purpose in life. We each get a certain degree of satisfaction from being able to pursue our goals. And so if your inability to pursue the goals that you had in mind, if your ability to pursue your own goals changes because of a disability, then how does that affect the person's psychological outlook? For instance, if you have a professional athlete that suddenly can't play his or her sport because of an injury, what does that do in terms of their role perception? A lot of our personal identity is often tied into our occupations. Self-esteem, self-confidence. If we look at social and behavioral theory, we know that people that are confident in their ability to carry out a certain course of action are more likely to engage in healthy behaviors. And then finally, cognitive impairments, things like memory issues, processing issues. How easy or difficult is it for this person to follow directions, or even in terms of their social relationships? We know that dementia and memory impairments can interfere with interpersonal relationships, which of course affects quality of life and psychological outlook. Level of independence is a big one for us. As PTs, very often our plan of care is directed first and foremost at regaining independence. And so independence has a lot of contextual factors to it also, right, as well. So let's go back to the example of a person with a spinal cord injury. You can have a spinal cord injury that results in paraplegia, for instance, and still enjoy a pretty high level of independence. When you go through rehabilitation and the PT, OT, and other rehabilitative professionals work with you and teach you how to get in and out of the wheelchair, how to get in and out of the shower, how to get dressed on your own, even though you don't regain the mobility in the legs, you can still enjoy a pretty high level of independence. Some of that also has to do with the need for assistance and whether or not that assistance is available to you. So you can have somebody that's a quadriplegic, for instance, that enjoys a high level of independence to a certain extent because they have a home health aide who's employed by them to help them get dressed or to help them get in and out of the wheelchair. Some of that will depend on the person's relationship with the individual who's providing assistance for them. So think about an older adult who's being cared for a family member, being cared for by a family member, rather. If that family member is resentful and takes that out on the patient, where that person becomes hesitant to even ask for help in the first place, they are going to have very, very limited independence. Social relationships, we all rely on the people around us to help encourage us through times of challenge. So for people with a physical disability, this can even become a more important resource. So the ability to have healthy social networks can very often affect the quality of life. Environmental resources, things that we've already talked about: finances, physical safety and security, secure housing, having an outlet for recreation and leisure, educational opportunities, and the availability of public transportation. If you can't drive yourself and there's no public transportation available, how much does that restrict the person's independence and ability to engage in community level activities and then therefore affect their quality of life? How do we assess quality of life? There's a number of measurement tools that we can use, and of course we try to think about which one of these tools might be the most applicable for our purposes. You have instruments that are used for the population as a whole. So if we want to look at quality of life in the general population, we might use something like the SF-36 or the shorter SF-12. And some of the dimensions of quality of life that these two instruments take into account would be the presence or absence of physical limitations and the severity of those limitations. If there are any social limitations, the presence of pain, general mental health, emotional health, vitality, which has to do a lot with energy level, fatigue, and the person's self-perceived health. Another instrument which is actually very useful in people with disabilities because it was designed specifically for that population would be the sense of well-being inventory. There's 36 items, so it's not really that quick to complete, but it does use a 4-point Likert scale, and the higher scores would help to indicate higher levels of well-being. One of the things that we need to consider is why we're measuring this. So obviously we want to see whether or not the person's disability is affecting their quality of life, but we can compare this over time. So if somebody has an acute onset of a disability, for instance, in a life-altering illness or injury, does their quality of life change even if the physical condition remains stable? And some of that has to do with healthy coping mechanisms and the person's overall resilience. We used to think that resilience was a fixed character trait, and what we've actually found out through research is that it is modifiable, meaning that people can learn to be more resilient as they adapt to their physical condition. And you can have two individuals with very similar physical impairments, like a spinal cord injury, and have two very different levels of outlook and quality of life. So related scales, we know that the amount of stress that you experience is closely related to quality of life. So we might use the perceived stress scale. There's an acceptance of disability scale and also the satisfaction with life scale. The nice thing about the satisfaction with life scale is that it's pretty quick to complete. There's only 5 items. It's also a pretty sensitive instrument. If you look at some of the other scales that we talked about, they only use a 4-point Likert, but the satisfaction with life scale uses a 7-point Likert scale. So it's a little bit more sensitive if we are going to do serial measurements where the patient completes this instrument repeatedly over time to see if their satisfaction is hopefully improving. Higher scores on the satisfaction with life scale correlate to higher levels of overall satisfaction. As we talk about the larger context of health and wellness, one of the things that we might want to consider is the best way to go about changing those social determinants. And one of the things that we'll consider through the course is the role of community-based participatory research, or CBPR. So let's look at an example of Native Americans. So if we wanted to help improve the health and wellness of American Indians, we might have to take into account certain contextual factors. First of all, there's all the cultural health beliefs, right? Even things like traditional healing. What's the role of traditional remedies in terms of promoting health and wellness? We might have to think of living conditions. Is this someone that lives on a reservation, and what's that like? Access to resources, even things like recipes. Traditionally, what type of foods does this community tend to eat? So community-based participatory research really involves the group from the start. So in this example, say we're working with a group of American Indians on reducing the likelihood of type 2 diabetes. And so we want to do a study that looks at the impact of exercise and patient education in this population. If we involve the community at the earliest level of planning, they may actually be able to suggest intervention design. Maybe they tell us that some of the recipes, the traditional recipes, that can be changed or modified a little bit to be more healthy in terms of maintaining better glucose control. And so we work with that, and then that shapes the intervention. It can also help in terms of needs assessment. What's the greatest need? Is it diet? Is it exercise? And then when we involve the community, not only do we have interventions that are more relevant for that particular group of people, but it's also more sustainable, right? We're building capacity within the community. Those people are learning how to take care of themselves so that when the physical therapist or the researcher leaves, they're able to continue with the healthy lifestyle without that outside help. And so I'm passing the torch to you now, right? You are indeed the future of the profession. And so as I become the graying of America, I am in that baby boomer group, and I start to think about retiring. Not too soon. I have at least 15 to 20 years before I get to do that. I want to make sure that my future colleagues are well prepared for the challenges that face us as a profession and as a population. And so what we want to do now is to start a class discussion, and I'll post a discussion board on Canvas for you. And by Wednesday, June 13th, you want to make your first post, and then by next Monday, make sure that you're responding to your classmates so we can really get a dialogue going. What I want you to do is think about the societal factors that we just talked about. And so those societal factors, as well as the shift in our profession's perspectives towards more community level health and towards more prevention, how are those two things going to shape your future practice as a DPT? I want you to give 3 examples. So for instance, for me, right, I graduated in 1990 with a bachelor's degree in physical therapy. So I'll get us started by telling you how this has shaped my practice as a PT. I went back, I got a master's degree in health education, so I was already starting to think about the role of patient education in prevention and wellness. And then after I got my transitional DPT, I continued to treat patients and integrate health promotion into my practice. So as a wound care specialist, lots of diabetes education, nutritional consults, exercise as a primary intervention for diabetes, and also a close professional relationship with a psychologist where I could refer patients who had diabetes and also had anxiety or depression. So those would be my 3 examples. And then you guys know that that was the impetus for me to go back to get the PhD in public health so that hopefully I can move beyond the individual or still address the individual, really expand the focus into more community health and wellness. I'm sure you will have lots of other ideas, maybe even thinking back to your recent clinical experience and see how an expanded focus on health promotion and wellness can help you be a better PT. All right, I look forward to seeing your responses, and I look forward to seeing all of you on Wednesday, June 13th. All right, thank you.